Hello, everyone. Welcome to the webinar. Thank you for joining us this morning. Apologies for being a couple minutes late. My name is Gail Broder, and I'm the Senior Community Engagement Project Manager with the COVID-19 Prevention Network. And I'm pleased to be joined today by a very accomplished group of presenters and panelists. And we hope to share with you a pretty solid overview of the world of COVID-19 vaccine research. We'll give you a bit of an introduction to some of the science that's informing our work, the results out of the early studies where we already have gotten vaccines approved with emergency use authorization. And then we'll have a good solid hour, our second hour, really devoted just to responding to your questions and interacting directly with our panelists and taking advantage of their expertise. A couple of bits of housekeeping. We would like to ask that if you have questions, that you put them into the Q&A box rather than the chat box. That helps us manage your questions more efficiently, and we can keep track of which ones are responded to and which ones remain open for an answer. So the Q&A box will be your best place to make note of questions. We unfortunately, Adrian Dominguez was not able to join us at the last minute. He had a conflict come up, so we'll unfortunately lose his unique perspective today, but I'm really pleased that Drs. Andrasik, Duran, McCormick, Wald will be with us, and we'll also be joined by Dr. Allison Roxby as well. And Dr. Wallace, excuse me, I missed one. So I think, Lewis, if you'll take us to the next slide, please. There we go. And one more. Here we go. So we've been very fortunate in our work as the CoVPN to be working with this terrific group of partners. And I would say that this describes a public partnership in all its glory. When the CoVPN was founded under the direction of Dr. Fauci at the National Institutes of Health, we began working with a whole range of both federal partners, faith-based partners, other research organizations, universities and academia. It's really been a tremendous opportunity to bring a lot of great minds together. And we wanted to just give you a taste of those partners here and acknowledge their help in reaching out to all of the various communities that we serve and making sure that we're hearing from all the corners of our society. Next slide, please. So to get us started this morning, we'll be led by Dr. Anna Wald. She is a professor in the Department of Medicine, Epidemiology, and Laboratory Medicine at the University of Washington, as well as being on the staff of the Vaccine and Infectious Diseases Division at the Fred Hutch Cancer Research Center. And she's also the head of the Division of Allergy and Infectious Diseases at UW. She directs the UW Virology Research Clinic, which is a clinic dedicated to the study of epidemiology, natural history, and vaccines for viral infections. And since the beginning of the pandemic, her clinic has shifted almost entirely to working on COVID-19, where they are currently focused on running the COVID vaccine trial with the Novavax candidate vaccine. So Dr. Wald, I'll turn it over to you.
Good morning, everybody, and thank you for joining. Can I have the next slide? So what I will provide is just a very brief overview of our approach to vaccine development and why we thought that this approach, which you will hear more about from Allison Roxby, turns out to be probably a correct one. So this is a picture of coronavirus. I'm sure all of you have already seen it. And as you can see, the surface of it is studded with these spike proteins. Now, these spike proteins are critical for the virus life cycle. Can I have the next slide, please? because really what these are the landing gear for the virus. So the virus can't land on a cell and inject its genetic material into the cell to replicate. Then really that stops the life cycle of the virus, and you can then really say that it's not even alive if it can't replicate. So very early on, we thought that understanding how to block the landing would be key in preventing of the infection. Can I have the next slide, please? So in this slide, you can see really the same concept that's being presented. On your left is the coronavirus with the spike protein sticking out. And on the right, you can see a cell in the human body. And that little glob on the cell is the ACE2 receptor to which the virus actually attaches. So there, can I have the next slide? And here you can see the actual attachment take place, and that is the necessary step in the virus life cycle, this attachment. Can I have the next slide? So you can see here, if we add antibodies to that, so those are produced by a person's immune system after they've either been infected or have been vaccinated. These antibodies are specific for the spike protein, and their binding to the spike interferes with the landing gear of the virus and prevents the binding to the human cell. Can I have the next slide? And that is really the key in understanding how we will develop a vaccine for a new pathogen. Here, what you can see is the development pathway for vaccines. And the first thing you have to have is really this idea of how you would approach it from a biological standpoint. And what I just presented to you about the landing gear and blocking it, that's the idea part. Then you try it in a test tube, then you try it in an animal, and finally, we move to human trials. And there are 3 phases of human trials. Phase 1 asks the question, is it safe? Phase 2 asks the question, does it produce an immune response that we think is relevant to preventing the infection and the disease? And then phase 3, does it actually protect against disease? And I think it's really important to understand that from the FDA point of view, before they allow people to use a new intervention, it has to be shown to be both safe and effective. Can I have the next slide? This is just to show you how a randomized double-blind controlled trial works. These are the trials. We already have the results from several of them, and more of them are in progress for other candidates because we really need all the vaccines that we can get. So in this kind of a study, you take a large group of people and you randomize them, so like flipping a coin, to either receive intervention, vaccine in this case, or control. And these studies use actually saline as control. And then you follow people over time. And unfortunately, regardless of how much we tell them to avoid exposure, in the United States, we have a pandemic, there's a very high rate of infection, and people will get infected. So then at the end of this trial, we count how many people in each group got infected to see whether if we can train the immune system to produce antibodies before it actually meets SARS-CoV-2, whether we can reduce the risk of being infected and the disease. Could I have the next slide? Now, normally, development of vaccines takes several decades. The trials take a long time to set up. There is a lot of paperwork that's involved. In addition, when companies invest in a vaccine, they want to make sure that each phase is finished and they carefully look at the results before they move on to the next phase. And that's because they don't want to invest unless the earlier data looks very promising. So what has been done to develop a vaccine for COVID-19 is to really compress all of this into a much shorter time frame. And as you can see here, normally what takes up to 2 decades has really taken less than a year. But I think it's really important to understand that all of the phases that we normally go through for vaccine development were still taking place, and that no safety corners have been cut before the companies were able to submit the data to the FDA to receive at this point an emergency authorization for the use of these vaccines. Can I have the next slide? And here, just to show you how quickly this was done. And the reason that this could be done so quickly was because there was extensive work that was done during previous epidemics of both SARS-CoV-2 as well as MERS in understanding the biology of these viruses and in experimenting with this new messenger RNA platform for vaccines. So you can see here in this very rapid timeline that the Wuhan was first, there was a first signal there may be a new virus, and that was in December 31st. And as you can see, really by middle of January, so within 2 weeks, the NIH has already known the sequence of the virus and decided that an mRNA platform will be the way for the first vaccines. And then if you go all the way to the right of your slide, March 16th was the first time that this new vaccine was injected in the human arm. And that is really unprecedented speed. Can I have the next slide? And the reason, just go ahead to the next slide. Thank you. And the reason that this was able to be accomplished in such a short timeline was because the government, NIH, invested in developing a COVID vaccine prevention network that is headed by Dr. Larry Corey and Dr. Kathy Nuzel, that really made it much easier to understand how to approach development of these vaccines and also harmonize the platforms. So that means that even though each trial was conducted by a different pharmaceutical company and uses a somewhat different construct, these trials really are using a very similar protocol, very similar laboratory assays, and a very similar approach to analysis. And as a result of this government-supported infrastructure, we're going to have really results that are comparable despite the trials being run by different sponsors. So this is just to give you a brief overview. And I think I'm going to turn it over. Can you go to the next slide to Dr. Alison Roxby to tell you more about these vaccines. Thank you.
Great, thank you, Dr. Wald. And I want to just confirm that Dr. Roxby is with us because I'm not seeing her.
Hi,
she is
I'm here.
Okay, she's just logged in as Michelle. That's okay. As long as we know that's you, we're good. All righty. So Dr. Roxby is an infectious disease physician scientist, and she is an associate professor of medicine, global health, and epidemiology at the University of Washington. And since the start of the COVID-19 pandemic, she has been involved in outbreak investigation and surveillance in skilled nursing facilities and in assisted living settings. And she has brought that particular expertise to our work at the CoVPN. Her charge has been to fully incorporate older adults into our COVID-19 vaccine research. So she has focused her efforts in 2 areas, community engagement directly with older adults and those who work with them, and also in providing expert protocol review to allow the fullest inclusion of older adults in our vaccine and monoclonal antibody studies. So Dr. Roxby, we look forward to your presentation. Take it away.
Thank you so much, Gail, and thanks to Dr. Wald for that excellent introduction. I'm going to be doing a research overview here of the 2 approved vaccines that we have, and I'll be going over some common questions that people ask about these vaccines. So let's go to the next slide. Okay, and please let me know if anyone's having any trouble hearing me. So we have two amazing vaccines under EUA, which stands for Emergency Use Authorization. So emergency use authorization means that the FDA has examined data from the companies and has determined that the vaccines are safe and efficacious for use. And it's a step toward full approval by the FDA. So as Dr. Wald mentioned, both of the vaccines that I'm going to talk about went through all of the phases of clinical trials to determine both safety and efficacy. And both of these vaccines underwent the most rigorous testing, which is the placebo-controlled randomized trial. And it's really important, again, to emphasize that the name of the research initiative was Operation Warp Speed, but as Dr. Wald said, speed did not mean shortcuts. All of the same research was done to prove that these vaccines were safe and effective. We were able to go faster because we had great funding and a commitment from all the government organizations to move as fast as possible to review the data presented and to make sure that we got approval as quickly as was possible. But no safety shortcuts were taken in the production of these vaccines. Next slide, please. So this is data from the Pfizer vaccine, which was the first vaccine to receive EUA. So first of all, I just want to note that there were 38,000 participants in this trial. So it was a very large trial that included a large group of people of different ages and different backgrounds. When you look at this trial, you'll see the red line shows people who did not receive the vaccine, but received the placebo, so a saline injection. And the blue line shows people who received the COVID-19 vaccine. And what we see is after around 14 days after the first dose, we see that in the placebo arm, people continue to acquire COVID-19. So every red box is a case of COVID-19. And in the end, after a few months, there were 275 cases of COVID-19 in the placebo arm. Whereas in the vaccine arm, after 14 days, we only had 9 cases of COVID-19 of people who received the vaccine. So the difference between these groups translates into an overall vaccine efficacy of 95%. And this was the data that was shown to the FDA that got Pfizer the emergency use authorization. And it's important to understand that after this data was presented to the FDA, the trial continued and people are continuing to record who got which infection to get additional data about the efficacy of this vaccine. Next slide, please. So similarly, these are the results that were presented to the FDA for the Moderna vaccine. And what we see is that, first of all, another very large trial. So there are 28,200 participants in this research presented in this data. They've presented their data a little differently. They're not showing what happens before complete immunization, but starting 1 week after the second dose of vaccine, when participants are completely immunized, you see that in the vaccine arm, we only had 11 cases of COVID-19. And in the placebo arm, for people who did not receive the vaccine, we had 185 cases of COVID-19 over about 3 months. So this difference between the groups translates to an overall efficacy of 94%, very similar to the Pfizer vaccine, and really a great result for vaccine efficacy. Next slide, please. So, wow, we were just so thrilled to have these great results showing that these vaccines work. These are both mRNA vaccines, which is a technology that as patients we're not as familiar with. So how do mRNA vaccines work? Well, mRNA is a piece of instructions that tell a cell how to make the spike protein from the SARS-CoV-2 virus. So after a participant receives an injection, the mRNA goes into their muscle cell And the mRNA from the vaccine gives instructions to the cell to make the spike protein. It's an empty spike protein because it doesn't actually have any virus or any danger. It's just like a mirror image of the spike protein. So the cell in step 4 makes the spike protein and displays it on its surface for a couple of days. And the immune system sees this spike protein, recognizes that it's foreign and it shouldn't be there, and creates an immune response to prevent disease. So that's how mRNA vaccines work. And it's really important to note that this mRNA from the vaccine doesn't stay in your body for very long. It's just there for a couple of days. And mRNA is a substance that's a bit fragile and tends to break down. And this is one of the reasons that the vaccines have to be kept so cold, because the mRNA doesn't last at room temperatures. Next slide, please. So although this technology is new to us as patients and consumers of vaccines, it's not new technology in the scientific community. In fact, people have been working on these types of vaccines for 17 years, and they've previously made other vaccines using this technology for other diseases, although the COVID-19 vaccines are the first to be FDA approved. And this technology is really great for pandemics because it allows for rapid development of vaccines, and that made it a great technology to use for this new disease of COVID-19. And I've just put a picture of the 2 researchers who were responsible for a lot of this technology development over the years, and who actually were responsible for the sequences used in the Moderna mRNA vaccine. Next slide, please. So I've just showed you 2 great vaccines that have gone all the way through the process and have the stamp of approval of the FDA. But we need research on other vaccines as well. So there are over 7 billion people on Earth, and all of us probably need access to this vaccine to control this pandemic. So there are 3 other major vaccine trials underway. There's the vaccine developed by Oxford University and AstraZeneca, which uses a chimpanzee adenovirus vector and has a lot of preliminary evidence showing efficacy, and is actually approved in some countries, although not in the United States. So in the US, there's a fully enrolled clinical trial that's ongoing, and we are hoping that the company will present data to the FDA soon. But at this point, this vaccine is not approved in the US because the company has not yet asked the FDA to review their data. Similarly, there's a company called Janssen in partnership with Johnson & Johnson who have been working with a human adenovirus vector vaccine. And this trial is also fully enrolled and ongoing in multiple countries. And we've seen some early release of data showing that this vaccine also is probably looking effective against COVID-19. But again, we do not have the FDA review of this vaccine, and it's not able to be used in the United States yet. And then there's a third company called Novavax, which is working on a protein adjuvant vaccine, which is more of a traditional vaccine technology, similar to what you might get with a flu vaccine or with a Shingrix. And this trial is also underway now and is almost fully enrolled for 30,000 people. And they also recently presented some preliminary data showing that their vaccine appears to be very effective, but again, has not yet been presented to the FDA. And then just yesterday, we got news about a Russian vaccine called Sputnik 5, which also looks very effective and has been published in a peer-reviewed journal. And there are many other vaccines in development, and I think we'll need all of them. We have a lot of people who need vaccine, and so we'll need to continue to get comfortable with different types of vaccines and different ways of developing vaccines for COVID-19. And then just want to remind us that we really also need research for children and adolescents who haven't been included in some of the vaccine trials to now, and pregnant women also haven't been included in the vaccine research up to now. Next slide, please. So I'm going to go through a few common questions and answers that people often ask about the 2 COVID-19 vaccines that have FDA EUA. And then, so next slide, please. Okay, so first question that a lot of people ask, were the vaccines tested on people like me? Yes. So interestingly, the FDA required from the very beginning that the vaccine trials include certain participants. So the vaccine trials had adults over the age of 18 years, and the FDA had said that at least a quarter of the participants needed to be over 65 years of age, especially since this is a population of concern for coronavirus. In addition, the FDA said that study participants had to include at least a quarter of people who had common health problems, things like high blood pressure, diabetes, cancer, or HIV. Participants with these problems were encouraged to participate in the trials. And as well, people who took medication or have other health problems were also included in the trials. The only type of medication that was not allowed to be included in the trial were people taking heavy doses of immune suppressing medication, because it would be hard to tell if a vaccine is effective if your immune system is not functioning properly. So for the usual middle-aged person who may have health problems and may take medication, these people were all included in the vaccine research right from the beginning. And so, yes, vaccines were tested on regular, normal people with typical health problems who take typical medication. We did not include pregnant people. That was the only group that was really left out of these vaccines. Next slide, please. Okay, do the vaccines work for all races and ethnic groups? This is a great question, and the answer is yes. There are small biological and genetic differences in the immune systems of people of different backgrounds. And sometimes people may have seen papers or internet things circulating saying, well, there's a different immune response in this racial group or that racial group. And those things are true. People in different backgrounds have different genetic responses to vaccines. However, overall, there's strong evidence that the vaccines work very well for all people, regardless of their genetic background. Put another way, even if we see a small difference in immune response between different groups, it didn't affect the overall efficacy of the vaccine in that group. Next slide, please. What types of reactions have been reported after vaccination? Very commonly, people report the following reactions: having a sore arm, getting a headache, having body aches, or even a mild fever. These are all similar to reactions that are seen after influenza vaccines or other vaccines like the shingles vaccine. Importantly, these common reactions are all brief and should be fully gone between 24 and 48 hours. There have also been rare reactions reported. There are some cases of anaphylaxis, and the CDC has followed this very closely, so we actually know how many cases. With the Pfizer vaccine, we've had 21 cases with the first 2 million doses, and with Moderna vaccine, we've had 10 cases with 4 million doses. So it's important to note that this is less than the typical anaphylaxis that we see with penicillin, a very common and considered safe medication. So because of these rare reactions, there's a recommendation that people be observed for 15 minutes after their injection, just to make sure that they're doing okay, and that vaccine providers have EpiPens at the site in case anyone has a reaction. And then any persons who have a history of severe allergies or of anaphylaxis are recommended to discuss and to be observed for 30 minutes after their vaccine. But it's important to note that most people with a history of allergies or anaphylaxis have received the vaccine with no issues. Next slide. Okay, a very common question is people asking, should I get this vaccine now or should I wait and see? You know, the idea that maybe it's a little early, I don't want to go first to get this vaccine. So a few things to think about if you're thinking along these lines. So the first is that as of today, a person getting the corona vaccine is not the first. There are 33 million Americans who've received one of these two vaccines. And around the world, there are 103 million people who've received these vaccines. So a person choosing to get a coronavirus vaccine today is not going first. And many, many people have received the vaccines before them. The CDC knows that people are nervous and have been monitoring safety very carefully. And they have a program called vSafe that you can enroll in that will send you text messages to monitor your symptoms and to allow you to report any symptoms that you're having. And then there's the VAERS, which is Vaccine Adverse Event Reporting System, which gives doctors a way to report any concerns that they have. But the most important reason to think about getting a vaccine sooner rather than later is that we do have the pandemic all around us. So last week in the United States, 21,000 people died of COVID-19. Cases are, I wrote cases are rising. This depends on where you are. Most people think that hospitalizations are leveling off, but there's still lots of community transmission of COVID-19. And these vaccines take 4 to 5 weeks to protect you fully to get both doses. Also, we're dealing with the new COVID-19 strains, which are more contagious. So if a person chose to wait to get vaccine, they wouldn't be protected when the new strains are here, and they'll be behind with those 4 to 5 weeks to get protected fully. So the official recommendation is if you're able to get a vaccine, getting it as soon as possible will provide you with the best protection. Next slide. Does mRNA change your DNA? There are lots and lots of Facebook posts about this, but the answer is no. So mRNA is a signal to your cell that goes in the outer part of the cell in the cytoplasm, and it doesn't enter the nucleus where DNA is located. So the mRNA from the vaccine has no opportunity to interact with your DNA and cannot join your DNA or become part of your DNA. And then just a reminder, the mRNA in the vaccine is only present in your body for a very short time, and then it degrades. And we know that it degrades because we're spending so much time, energy, and resources keeping these vaccines cold so that the mRNA will stay stable. So just remember, the material from the vaccine is really only in the body for a very brief period of time. Then it breaks down and it has no opportunity to interact with your DNA. Next slide. Why do I have to wear a mask after getting immunized against COVID-19? Such a challenging question. Well, although we're starting to get little bits of data on this, the 2 vaccines that are approved in the US, Pfizer and Moderna, are known to prevent COVID-19 severe disease and death. But we don't know if they prevent asymptomatic infection, which is keeping the virus from replicating in the nose, which is how we transmit it to other people. So there's concern that, I mean, it's great to have asymptomatic COVID. That means that you don't get sick and you won't die, but it doesn't mean that you can't spread it to other people, especially unimmunized people who you may be living with. So we don't know the answer to that. We're hoping to have more information soon. The second issue is that vaccine efficacy is not 100%. So there's still a small number of people who were vaccinated but did come down with COVID-19. So for people who really don't want to be getting sick with COVID-19, to be 100%, you need to continue to do the other prevention methods, which is masking, social distancing, and hand washing. So again, we really need to have patience about this question. I think we'll have more data. But the third way I'd like you to think about it is that, you know, we have a giant community outbreak of a contagious disease. And in those situations, we do need to take precautions and not just rely on immunization. And I think, you know, if we had measles circulating at Disneyland, most of us who've been immunized against measles would still not go to Disneyland during a measles outbreak. And so, you know, immunization is one of the ways we protect ourselves, but we also have to protect ourselves using the other ways that we know how. Next slide, please. Is 1 dose of vaccine as effective as 2 doses? Well, we'd love for this to be true because it might enable us to immunize more people, but the data are very clear for the Pfizer and Moderna vaccines that the best protection happens after the 2nd dose, which is the booster dose. So the 1st dose gets the immune response started, and the 2nd dose boosts it to make the high antibody levels that you need for protection. So unfortunately, well, fortunately, we know the answer to this question. The data is very clear, and sadly, we definitely need 2 doses. Next slide, please. Okay. How long does vaccine immunity to COVID-19 last? We don't know. This is a brand new human disease, and we're still trying to figure this out. And that's one of the reasons that the research trials are going to continue for 2 years. Now the placebo recipients in the trial have been given the COVID-19 vaccine, but we'll continue to follow those recipients and learn about their vaccine responses. So we don't know, but we will know. We're studying this. How will viral mutations affect COVID-19 vaccines? This is a great question. We don't know exactly. We have some concerns about some of the viral mutations. People are doing a lot of experiments in test tubes to see how the viral mutations will affect COVID-19 vaccine response. And there will be other viral mutations, not just the ones that we're working with now, but there will be future viral mutations. So we're not sure, but scientists are actively looking at this. They're tracking this, and we're getting this information as quickly as we can. Some of the early data seems to suggest that even if there are viral mutations, that the vaccines still protect against the worst outcomes, which are hospitalization and death. But again, we're very early in this process. Next slide, please. Okay, so that's the end of my question and answers, and we're looking forward to getting into more of this information with you soon. Thank you.
Great. Thank you so much, Allison. And I see some great questions in the Q&A box coming up that I think would be good just to get some clarity before we open it up to the panel. We have had a couple of questions about GI symptoms, vomiting, stool, diarrhea, issues like that. Are these symptoms that are in any way linked to vaccination? Are they linked to COVID? Could they be something else?
That's an interesting question. I haven't been tracking any increase in GI symptoms among those who received the mRNA vaccines, and that hasn't been published as a potential side effect.
Great. We've also had a question about any deaths. Have there been any deaths reported among people who've been vaccinated?
In the clinical trials, there have been no deaths reported that's considered to be due to vaccination. Right now, as you noted, there are 33 million people who've received the vaccine. So in a typical population size that large, we would anticipate that some people would die from a variety of causes in any given time in that large group of people. But the CDC has not reported any deaths associated with the vaccine.
Maybe I can add here, there is one death that the newspapers consider associated with the vaccine that's been heavily covered in the popular press. And that is a person in Florida who received the vaccine and then developed ITP, which is a low platelet count, and ended up bleeding into his brain and died as a result of it. I think this happened after the vaccination in a short period of time, and there's concern that it was related, but it's still incredibly rare, even if it was related. But I just wanted to sort of talk about it because I know that people have heard about it.
Excellent, thank you. And another question about the people who were in the studies. This attendee has asked about people who are living with HIV. Were they included in the trials? And does their compromised immune system in any way limit their responses to the vaccine?
That's a great question. So persons living with HIV were included in the trials if they were considered to be stable with HIV with an undetectable viral load and a CD4 count higher than 200. In general, persons with immune compromise from whatever the cause, be it HIV, be it cancer treatment, be it transplant recipient, typically they respond slightly less to vaccines than people whose immune system functions well. but usually it still gives them an edge against the infection, and typically they are recommended to receive vaccines. So first of all, people with HIV were included in the studies, and second of all, people with immune compromise in general probably have slightly less beneficial responses to the vaccine, but it probably still helps them, and we're hoping to have additional data from this soon.
Great. Dr. Wald, this is probably a good question for you. We have a question about whether the spike protein feature is unique to coronaviruses, or can this technology be used with other viruses as well?
Really a great question. I think it's limited. This type of spike protein, this type of landing gear is limited to coronaviruses. So I'm hoping that eventually we can make a vaccine that will cover all of the coronaviruses, not just SARS-CoV-2, sort of a universal coronavirus vaccine, but probably will not cover other viruses because their landing gear is a little bit different.
Yeah, and I think it's important to note that mRNA has been studied in other diseases. There are trials in HIV and Ebola. Those studies just have not gotten to the point of being licensed yet, so we haven't been hearing about them in the media, but this mRNA technology is definitely being tested against other diseases as well. But I think that's a great point, Dr. Wald, that each virus is unique, and they're all shaped differently, they behave differently, they attach differently. So we have to treat each one as an individual puzzle to be solved. Important distinction there. We've had a couple of questions, and I think this is a good place to just maybe restate a little bit or clarify a little bit about the difference between a vaccine that can prevent disease and a vaccine that can prevent infection. And so we've got several questions that are talking about, how will we know if we can stop wearing masks? How will we know if we are preventing transmissions? What is the information that we're needing that's going to get us to that place?
I'm happy to speak about it. This is an issue that's very actually close to my heart. I'm very interested in the answer to that question. And I think the problem right now is we don't know yet. I think we will understand better in several more months to what extent these vaccines not only prevent disease, but also prevent infection. So for now, since we don't know anymore, we still need to wear masks and keep physically distance. Having said that, most vaccines also work to prevent infection, although they are often not as effective in preventing infection as they are in preventing disease. So I'm hopeful that we will see at least partial protection against the infection. The other thing is that the studies that are being done are not only looking at the disease, but they will also look at antibodies at the end of the study. And they will be able to tell how many people in the trials were infected but did not have any symptoms, and compare that between the vaccine and the placebo group. And I think that will provide really important information.
Excellent. Okay. The rest of the questions that I'm seeing coming in are a perfect segue into opening things up to the rest of our panelists. So I think before we go that route, let's hear from the rest of our presenters first. And here, I think up next is Sally Bach. So Louis, if you could bring up Sally's slides, we'll hear that portion of the presentation. And then we'll circle back to more of the questions in the second part. So Sally is the Senior Director of Marketing for the COVID-19 Prevention Network, and she has worked on brand and marketing campaigns for a range of organizations, everything from Fortune 500 companies to smaller nonprofits, including helping to launch and create the Give Big campaign for fundraising in Seattle, as well as some national initiatives that are focused on health disparities that were funded through the Robert Wood Johnson Foundation and the W.K. Kellogg Foundation. So Sally, please tell us some more about all of the range of tools that we have available to us for community engagement work.
Thanks, Gail. Yeah, and I just want to emphasize the fact that I'm presenting tools and tactics. How do you communicate this information, and what are some things that we can make available to you to make that easier? This sits within a much larger, deeper, robust community engagement practice that the CoVPN and Fred Hutch has been building for decades, which is really about deep relationships and working together with communities. So the materials that I'm going to share with you have had a lot of community input and are responsive to what we hear from the community. So I don't want to have anyone mistake that these communications materials are the net sum of what community engagement looks like as part of the CoVPN. However, we've just presented a lot of information, and for many of you, you have the job of conveying this to the communities that you are a part of. And so we wanted to give you access to those tools to make it easier for you. Next slide, please. So before I start showing you the tools, I thought it would be helpful to take a look at where people's attitudes are currently about the COVID vaccines in terms of the acceptability of it and their intention to take it. This is a national data, and I'll talk a little bit about how it looks different in Washington in a second. But you'll see that people kind of fall in one of four camps that are essentially equal in size, starting at the resistant, people that are really trusting in other approaches to protection and to managing the risk of being infected with coronavirus, and not interested in vaccines. There's a group that's skeptical, so they're not sure and leaning more towards being resistant. There's a group that's open but still is uncertain, has a lot of questions still that they want to have answered, and also may have questions about what information should they trust to feel confident in the decision that they're making. And then about 30% that are currently intending to get the vaccine as soon as it's available to them. In Washington, our intending group is slightly more than 50% of population. There have been a couple of studies that have looked at public attitude about that, and the numbers are really similar. And then it's more like another 25% that are in that skeptical and uncertain, that would like to wait and see what other people's experiences are, what other data or findings happen as research continues, and then about 25% that are in that resistant camp. So I think that's helpful. It's easy in the news to just see the people that are in line and trying hard to get a vaccine, and to forget that there's a half of the state that still has a lot of questions that they want to have answered. So next slide, please. When we look at that demographically, we see that there is lower intention in Black, Hispanic, and younger populations, more also, more in that wait and see group, and then you see resistance actually, interestingly, is strongest in the 35 to 49-year-old group, the sort of hard set resistance. Next slide, please. And this is again national data. So what are the reasons behind it? Well, it's a new disease and it's a new vaccine for a disease. So there are a lot of questions and concerns about the benefits, the safety, and the side effects. It can be hard to understand how it can keep me from getting very sick, but it doesn't keep me from getting infected. And is that meaningful? What are the safety concerns? What are potentially long-term safety concerns or side effects that we just haven't had time to see? Questions about, this happened in record speed. Is that okay? Do we have enough data? Did we cut corners? And then, when we present data, well, do any of those people look like me, have experiences like me, have maybe health conditions like mine. So can I look at that data and apply it to my own circumstance and feel confident? Who was behind this? What were the political and economic motivations? There was certainly plenty in the news during this process that I think people were uncertain about and had questions about. So, is it a trustworthy process? Should I trust it? Because are the actors behind this trustworthy? And then, establish have been around for literally centuries since vaccines started, and then new ones that are unique to COVID and to coronavirus. So next slide. Our approach to that has been to get information to people to help them make informed decisions, and understanding that being hesitant, having questions about the trustworthiness are all very understandable and a point of conversation, not a problem to solve necessarily, or people whose minds need to be changed, but giving people good information so that they can make their own assessment. So we have been doing this for the last 9 months, as we have been encouraging people to volunteer for the clinical trials. And then as some of the vaccines have been authorized, we've been in the position of needing to communicate to people, well, what do we know from the trials about those authorized vaccines, and helping people unpack that and understand that. And we, for this group, have created a Dropbox where all of these literally hundreds of assets live. And at the top of the slide, you'll see tinyurl.com/COVID-19 materials. And in that Dropbox, you will find a great breadth of materials. And just a few of them are here. There are animations and infographics, ask an expert video, snackable video bites, answering questions that have come up in many of the Facebook Live events that we've hosted, or in other sort of town hall type venues. There are slide sets. There's been a lot of interest in this particular slide set. There are slide sets that help explain coronavirus and the COVID vaccines, should you need that for a presentation style. There are social media posts taking much of the content and putting it into formats for Facebook and Instagram. And then there are educational videos that walk through at a deeper level than that snackable content for social media, walk through the material and interest. And this Dropbox is something that will be dynamic and will be continuing to add to it. So please go spend some time with it. Hopefully it's quite easy to navigate and clearly labeled. And we welcome feedback if you don't find it to be that, but we'll also continue to add to it. So check back off. I want to share a couple of the pieces of content now, just to give you a better sense of what they are. So the first one, Lewis has got some fancy footwork to do, changing the screen. So this is an animation that you'll find in the Dropbox, which is a little under 2 minutes to help explain how do the mRNA vaccines work. So the mRNA vaccines, in case you've lost track, because there are so many vaccines, are the Pfizer and the Moderna vaccines. They both operate in the same way, even though they're slightly different. Lewis, I think we need the sound on. Let's see, if you stop the share, and when you go back to share screen and you choose it, there are little boxes on the bottom that will say share computer sound. Nobody ever, it's an
What is an mRNA vaccine and how does it work? Both Pfizer and Moderna are messenger RNA vaccines. They teach your body how to recognize the virus and fight back. What happens when you're infected with coronavirus? Viruses can't replicate on their own. To multiply, they attach to host cells and use them to make copies of themselves. The new coronavirus does this by attaching to a healthy cell using the spiky proteins on its surface. Once inside, the virus takes command of the cell's machinery and starts making copies of itself that can attack other cells in your body. To fight the infection, the body makes an immune response specific to the virus. These antibodies and fighter cells attach to the virus and allow the body to clear it out. What do the mRNA vaccines do? These vaccines get the virus's genetic information to your immune system before you are infected, so that if you do come in contact with the real virus, your body already knows how to fight back. How? The vaccine uses the genetic code for the spike protein on the surface of the virus. The vaccine carries it with a message that teaches the body to make the protein itself. It's like showing your body the recipe for making spike protein. When injected into healthy muscle cells, the mRNA instructs them to start making the spike protein. The immune system sees this spike protein and responds by making an immune response. The immune system will remember the spike protein and, if it sees it in the future, it is ready to respond.
Thanks, Louis. And I just see that there's a question that came up asking again how to get these. So when you go to tinyurl.com/COVID-19, 19 is important, COVID-19 materials, it will open a Dropbox that you'll have access to, and there will be folders of all the material types, and you can directly download from that Dropbox any of these assets, and you are welcome to use them in any of your communications channels. They are for community use. All right, and here's another example of a social post of Dr. Fauci asking one of the really common questions about why do we need 2 doses?
That's just the way the immune system responds. We know from practice and experience that with some types of vaccines, you require a prime, which gets all of those immune cells sort of triggered and ready. Then you come in with a boost and the response really takes off. So based on considerable experience, we know that a prime followed in 28 days by a boost gives you a much more potent and durable response than just a single injection.
Thanks, Louis. I'm going to see if I can share my screen and show you the Dropbox. Don't know that I have the ability. It does not look like. Oh, wait. Sorry, everyone. Okay, hopefully you're seeing my screen. Gail's nodding, great. So this is, I have entered that tinyurl.com/COVID-19 materials, and this is the Dropbox that opens up. And so you'll see that there are 4 folders here of the different types of content. And then within them, you'll start to see the individual pieces. I will take you into the social media for just a second because it works a little bit differently. So the first thing that you see is a README in the social media. And this then takes you to either the creative assets individually, or what I think is much more helpful, if you go into this gives you a menu, which starts out by breaking down how to read each of the slides. So where the post description is, what type of content it is, etc. And then as you go into the different, there's an index. So there's Vaccines 101 section, and then there's a section on trusted voices addressing concerns. And then as you go through, you can see a little bit of a preview of each of the pieces that are included and can click then on this link to asset to get the original asset. So this, for example, is a Spanish post that explains how vaccines work. So there's the graphic, and then here's the link if I want to download it. Okay. Back to the slides, if you would, Lewis. And the next slide, thanks. So again, in that Dropbox, in the infographics, these are just some screenshots of 4 of the most asked for ones. The first is, what did the COVID vaccines do? What do we know about them? What we don't know about them? How do the mRNA vaccines work? How do we understand population immunity? How does it work? What does it mean? And then a breakdown of the overall types of COVID vaccines. So next slide, if we just take a look at one of them individually, and again, these are all available to you in the Dropbox. This is a point that Allison was bringing up in her presentation of what is it that we know that vaccines can do for us. We know that they can keep us from getting very sick, sick and very sick, but they can't keep us from getting infected. So what else do we need to do? And just reminding people again that we need to continue to wear masks, wash hands, and keep physical distance. So this infographic is something that you can download, you can size, you could drop into a newsletter or onto a website or print out and use as a poster. Very flexible piece. And as I said, there's a series of those in there. All right, well, I'm going to pass it on to the next presenter and back to Gail.
Excellent. Thank you so much, Sally. And we're getting some great questions in the chat. So let's introduce, among those questions is, could you please repeat that URL address? So here it is in big letters across the bottom of the screen, tinyurl.com/COVID-19 materials. And we'll leave this slide up for a little bit so that everybody gets a chance to write that down, because I've seen it come up in several questions. So let me take a moment and introduce the remainder of our panelists to you, and then we'll open the floor for some Q&A and discussion. The first of our panelists is a wonderful lady who I am privileged to call my supervisor. She is Dr. Michelle Andrasik, and she is a clinical health psychologist and the director of the social behavioral sciences and community engagement teams at the COVPN, and also our predecessor network. We started out as the HIV Vaccine Trials Network. She is a senior staff scientist at the Fred Hutch, and she's an affiliate clinical professor in the departments of global health and occupational environmental medicine at the UW. Dr. Andrasik received her PhD in clinical health psychology from the University of Miami, and she also has a master's degree in health education and psychological counseling from Columbia University. I'm also joined by my teammate and friend, Dr. Stefan Wallace, who is an expert in developing, implementing, and evaluating major public health and human service programs in the areas of prevention, care, and treatment of HIV and AIDS and other infectious diseases. He's the Director of External Relations for both the HIV Vaccine Trials Network and the COVID-19 Prevention Network. And he leads the network's external relations strategies and the efforts in that program globally, with a focus on building long-term relationships with our key stakeholders. He has more than 2 decades of experience in sexual and public health, social justice, and community mobilization work with diverse populations around the world. We are also joined by 2 of our expert panelists today, Dr. Bonnie Duran, who is of the descent of the Opelousas and Coushatta peoples. She is a professor in the schools of social work and public health at the University of Washington, And she is also on the leadership team at the Indigenous Wellness Research Institute. She teaches graduate coursework in community-based participatory research and in mindfulness. She has worked in public health research, evaluation, and education among tribes, Native organizations, and other communities of color for over 35 years. She is currently the principal investigator of 2 different NIH-funded research projects being conducted in Indian country, working with the American Indian Higher Education Consortium, 22 tribal colleges, as well as collaborators at the University of Washington. Her research aims to work in partnership with communities to design health access and prevention efforts that are empowering, culture-centered, accessible, sustainable, and that have maximum public health impact. And we're also joined by Dr. Wayne McCormick, a professor of medicine at the UW in the Department of Medicine and in the Division of Gerontology and Geriatric Medicine, and, the Division of Gerontology and Geriatric Medicine at Harborview Medical Center. I missed a comma there, sorry. Dr. McCormick holds the William Colson Endowed Chair in Gerontology, and he is the medical director of Bailey Boucher House, which provides long-term care services and day health services for people living with AIDS, as well as other kinds of long-term chronic health conditions. He directs the Palliative Medicine Fellowship at the University of Washington, and his research focus is in health services research and the epidemiology of dementing illnesses such as Alzheimer's disease and other chronic diseases, including HIV in older persons. He is the co-investigator for clinical and epidemiological studies of older persons, including a study called Adult Changes in Thought. And he is involved in several quality and process improvement projects in palliative care and hospice settings. So a very distinguished panel of guests with us today, and we look forward to all of their insights and input. So I want to bring us back to some of the great questions that we are getting in the chat here. One of the questions that has come up from several different people, and I'll put this out to any of the physicians who'd like to chime in, is that people have seen information that advise against taking Tylenol or ibuprofen before getting vaccinated. And when is it okay to use those medications? Should you use it afterwards for side effects? What's this about not taking it before? Can someone help us sort out Tylenol and ibuprofen? Allison, I just saw you unmute. You want to start us off?
I think the recommendation is that it is okay to take these agents if you have symptoms. But since many people get the vaccines and have no symptoms, it's not recommended to pre-medicate. So get your vaccine, and then if you're not feeling well, feel free to take medication. But you may be in the group of people who don't have any symptoms and you wouldn't need it.
I'm seeing Dr. McCormick nod. I'm seeing Dr. Wald nod. Everybody's in agreement around that? Okay, excellent. So we've got that one cleared up. Let's see, we also had a great question. And Sally, perhaps you might want to speak to this, or maybe Dr. Wallace. When will the COVID vaccine materials be sent out in more languages than just English and Spanish? And how can we serve other BIPOC and immigrant communities?
I do not have a specific timeline for when they're going to be available. We have had several partners reach out to us to help with translation, and so we're pursuing those. We know it's important, and so as soon as they're available, we'll share them, but I'm afraid I don't have a concrete timeline.
And I can also say, that we have provided all of these materials to the Seattle King County Public Health Department and with the Washington State DOH. And I know that they are working to create their own materials based on the materials that we shared with them in local Asian and African languages. So you can check the Washington State Department of Health. They've got a great website on COVID, as does the Seattle King County Public Health Department.
Okay. Excellent. I think I'll start by directing this one to Dr. Wald, but maybe any of the physicians could chime in. There are several questions around people who have already had COVID and whether they should get the vaccine. And do we have a reason to think that vaccine antibodies would last longer or somehow work better than the natural antibodies that are produced when someone has a natural COVID infection?
There's a lot there to, I think, unpack. So first of all, we know that most people who have COVID-19 have antibodies afterwards. We don't know yet how long they last. And we know that reinfections are rare. So you're not completely protected from having COVID again. The vaccines thus far seem to create antibodies that are at least as high, and most of them actually create antibodies that are higher than natural infection. I think it's really important to understand that some vaccines are better than nature and can actually provide a more long-lasting and a stronger immune response than the natural infection. So in people who have had COVID-19, at this time, the recommendation is to wait 3 months, both because we actually don't think they're probably at risk because they probably do have a good immune response that lasts at least as long. And also because I think that's a more appropriate timing for them to really recover from the illness and then come up when their turn is to be vaccinated. So the vaccination is still recommended, but not immediately after.
Excellent. Bonnie, a question for you. Can you talk a little bit about some of the successful strategies that have been used to convey COVID information to our tribal and Native communities?
Yes, that's a great question. And right now there's one organization, we're so lucky it's local. The Seattle Indian Health Board and the Urban Indian Health Institute have done an excellent job of creating materials. Well, first of all, they did a survey because there wasn't a lot of data, you know, American Indian, Alaskan Native, Indigenous, you know, often gets under-researched by national or even state organizations because supposedly of our small numbers, but they went out and did a survey. They got about 1,500 people to respond to it. And they found out that actually Native people were much more likely to get a vaccine. In fact, we had 75% of the people who responded to that survey said, yeah, I'm gonna get a vaccine. And I love it. It was because it wasn't about me, it was about we, as they say. It was about protecting elders and protecting others in the community. And, you know, in order to maintain culture and to continue with the cultural revitalization that's really central to all urban Indian and tribal nations in the country. So one is to really, is to have educational materials based on that. There's some wonderful materials. You can actually go to the Urban Indian Health Institute website and see their materials. They have wonderful pictures of, you know, masked up people saying, be a good ancestor. You know, this is what you're doing for your future generations and for the elders and cultural keepers in your community. I got a Pfizer vaccine on Sunday. My partner, who's Japanese American, has worked for the Makoshi tribe for 20 years. And they just told everyone, you know, if you are one of our community, get in line and we will give you a vaccine. So on Sunday, we headed out there at 8 o'clock in the morning, and there was, you know, there actually wasn't a long line at all. And he got a vaccine and I was his partner, and they said, you're a community member. So I got a vaccine too. It was wonderful and incredibly warm and welcoming and loving community. So I think that that's, you know, one of the advantages, or one of the things that I think other communities of color probably are doing similar things, but it's really about not the me, but the we. Yeah.
I like that. Not the me, but the we. And that's actually a perfect segue, Bonnie. You didn't even know you were doing it, but it leads great into the next set of questions. And we've had it, this sort of the same issue raised from a couple of different angles. People who are asking about if we don't know whether the vaccine prevents transmission, then how will it protect others? And then the flip side of that question is someone who asked, if transmission is unlikely, can we say any more about what's the probability of transmission to others? So we're kind of seeing the different facets of the same issue. Would any of our physicians like to chime in on that?
I would like to ask Allison to address it. I feel like I spoke about it. There's not consensus right now because we don't have enough data, but Allison, please go ahead.
Well, the way I've been thinking about this is that in order for this vaccine to work, you have to have coronavirus in your nose, because that's where your body is going to see the coronavirus and your immune system can protect you. So if you have coronavirus in your nose for some period of time, you're going to be contagious once it's in your nose and replicating. So what we don't know is, how quickly the virus is able to control the coronavirus in your nose, which is the way it goes out to other people. So I think when you think about it that way, you realize that vaccination is part of a strategy, and the way we control the pandemic is going to be for not only everyone to have protection, but we really need to see the case count in the community to come down before we're going to be able to remove some of the other issues that we're doing. So masks and social distancing, when we have tons and tons of virus out in the community, the vaccine can only do so much. So just remember, the vaccine has to get into your body, and it gets in through your nose, and that's where your protection comes from, but that also provides this opportunity for contagion.
Yeah, and I think it's really important to keep emphasizing the word yet. But we don't have these answers about whether it protects against infection and transmission yet. And that's because we're in some ways the victims of our own success. That these studies were designed to collect the samples to answer this question at a later time point in the clinical trial. And we got the answer about efficacy faster than we expected. So we haven't actually gotten to the point of the clinical trial in some cases where these samples are going to be collected. So this is data we will have. We just don't have it yet. We have to keep reminding ourselves to let the time unfold. So coming back to the questions in the chat, we have a number of questions around, and I'm going to look especially, I think, to Dr. Andrasik and Dr. Wallace, questions around the inclusion and serving our different BIPOC communities. Have we done anything to address implicit biases amongst the staff of vaccination programs and in the serving of the different BIPOC communities? Can you talk a little about how we're working with these groups?
Yeah, so one of the things that we've been doing, we're working with the mayor's task force to plan rollout in BIPOC communities. So we've identified several community partners who are able to open sites at churches, community centers, and there are already actually a lot of individuals doing this work. For example, about 2 weeks ago, there was a vaccination effort at the Ethiopian Community Center that vaccinated over 106, or not over 106, 106 individuals. They had planned to vaccinate 100 and vaccinated 106. So we're really trying to create more of those opportunities for vaccination within communities by community members who are volunteering and working to staff those vaccination sites. One of the challenges that we're facing now is limited supply of vaccine. So we're really working to gear up those efforts so that when we have a consistent flow of vaccine into the state, that those sites within communities will be up and running and ready to vaccinate. I know the mayor's office is also working with a large pool of mobile vaccination clinics, and they're working now to identify the best places to send those vaccination clinics to. And Robin, I saw in the chat that you had suggested apartment buildings with immigrant and BIPOC communities. If you can send me some of those, the mayor's task force is asking for spots so they can figure out the mobile van, locations, and certainly, we can bring that into the conversation, because I think that that's really critical to make sure that we're identifying appropriate spots for those mobile clinics.
Excellent. Dr. McCormick, what are you seeing in terms of vaccination rollout to our seniors and to the staffs of long-term care settings? What's your take on how we're doing in serving those communities?
I think we're doing very well. I should mention that Allison was part of a big effort months ago, maybe not a year ago, but many months ago, serving as what was then called drop teams that Allison helped coordinate, dropping into nursing homes, since it seems like ancient history, but the Pacific Northwest experience with COVID began, at least in the newspaper, in nursing homes, the one in Kirkland. In any case, Allison and her team would descend on a nursing home and test everybody, all the staff and all the patients, everyone who's willing, to find out what the spread was. And Allison maybe can speak a little bit about this, but they encountered enormous variability. Some facilities that they thought everybody would be infected, nobody was. The next place they'd go, excellent, outstanding, spotless nursing home. They thought, oh, well, we won't find any cases here. Everybody was infected. Slight exaggeration, but anyway, they encountered enormous variability. But we should call out the valor of Allison and these teams, because back then we didn't know much about COVID, and we still have a lot to learn. But these folks were, engaged in a pretty risky enterprise, doing this day after day. So I want to commend them in that work. But what's happening now is really remarkable, and that is I've personally witnessed a new type of drop team, and that is vaccinators. In large part these days represented by a couple of large pharmacies in our community. And several weeks ago, I saw the team descend on the nursing home I go to and vaccinated the entire staff, all shifts, 146 persons, all residents. And it took them about 5 hours to do that. That's remarkable efficiency, and everybody accepted. And I've heard of that replicated in many nursing homes. Allison may know, I don't know, but I think a substantial majority of skilled nursing facilities in the metro area are now done with that, and maybe even done with their second dose of vaccine. And it's being spread out into assisted living facilities and other buildings like that, adult family homes. So that's remarkable. The other thing I thought I'd mention is, there are a surprisingly large number of older people in our metropolitan area. And in my clinic, I routinely see people in their late 90s and over 100. It may surprise you all to learn that there's well over 500 people in King County over 100 years old. It's not even newsworthy anymore to be over 100. Anyway, and a substantial majority of people over age 75 in our community are completely healthy. They have no medical conditions and no physical or thinking impairments. Don't need a doctor. but a fair number of them do have debility. And their variability that Sally talked about earlier with acceptability of the vaccine varies tremendously, because currently they're now all eligible. All of my clinic patients are eligible in, we haven't talked about the phases, but they're people over 65 now can receive the vaccine if they can find a vaccinator to do so. And I thought I'd tell a brief story. I saw a lady a couple months ago. I shared this with Michelle a couple months ago. A lady in her late 90s came to clinic, and this was her son and grandson were on Zoom with the clinic visit. She was physically present. This is a woman from a large African-American family. And she wanted to know about the vaccine, as did her son, who was 74, and her grandson, who was 48. And she said, well, I want my son and grandson to get the vaccine first. I know I might be eligible first, but I want them to get it first. And this was a woman who had stood, fearlessly between her children and an angry mob in Alabama when her kids were about to join an integrated school. So what I read into that was sacrifice, love, devotion. But I think back in there was a little bit of fear of the vaccine too, maybe. But regardless, that's a different sentiment. Unique sentiments might arise in older people. And I told her, well, we just don't know who's going to get COVID, and we don't know who's going to spread it, and we don't know who's going to super spread it. So when your name comes up, it's a good idea to probably go ahead, get in line and get the vaccine. And I was told a few weeks ago that her son was going to take her to get the vaccine along with him, because he's eligible too. Grandson's not ready yet. So I think if we encounter resistance, it's good to talk those things through. And if Allison has any other words of wisdom about the drop teams and the vaccine teams now, it'd be good to chime in.
Thanks so much, Wayne, for your kind comments. I appreciate it. I think so what we've seen now in COVID for older adults is that the people in congregate settings are going to be relatively easy to get vaccinated. And there are a lot of plans in place for people who live in senior living and assisted living and other settings. But for people who live at home, either in a multi-generational family or by themselves, it's much heavier lift. And I see a lot of these comments about how are people supposed to navigate with the internet and trying to figure out how to get themselves signed up. And it's become apparent to everybody in the last 3 weeks that for homebound elderly and for people who are not computer literate, that we have to evolve better systems to enable these people to vaccinate. But interest is high. So I think we have a lot of demand in that area, but we're not able to supply both vaccine and an easy method to get people signed up. So this is the next frontier for all of us in community health, is coming up with better systems to serve this population.
One thing that's remarkable about these vaccines is how effective they are in older people. And maybe Anna would want to mention that, but that's unusual. A lot of vaccines aren't as effective in people of very advanced age. These seem to be effective.
Anna, do you want to say any more about that?
No, I think I agree with what was said. Yeah.
It's a pleasing result.
Yes, it is. We just need more vaccines.
Exactly.
The bottom line is we just need a lot more.
I was going to make that comment as well, that, I've seen a couple of questions addressing this, how do we get appointments? And the challenge that we're seeing right now is, again, something that we're a little bit victims of our own success, that we thought it was going to take us 7 months to get study results, and instead we had results in 4 months. And that means that we lost 3 months of production time. So right now, just the sheer manufacturing burden is what's really the barrier, that it takes time to manufacture the vaccines and all the little glass vials and all little rubber stoppers and all the syringes. All of these supplies for vaccination take time to prepare. So that is a stumbling block that I'm not sure any of us gathered here today can address. I heard something that, oh, please.
This is actually my thoughts, Wayne, about the anecdote that you just said about the older woman who wanted her family, her son and grandson vaccinated first. And I do think that deciding on the priorities for who should be vaccinated is really difficult. And I think we all struggle with how to make that decision. And the disparities in the poor outcomes are much greater, for example, in people of color or indigenous communities at a younger age, right? So for example, I know Canada has prioritized indigenous people for vaccination regardless of their age because of that. And how do we balance these things about people who are, yes, they're older, but as Allison said, they live in a very protected setting, right? And might not be at risk, versus somebody who is much younger, but may have other risk factors and may be in an essential position, which exposes them to coronavirus. So I don't have the answers, but I think through this every day about how we can do this better. And is there a better approach for this? So I just thought I'll share that.
I want to
throw your hand up, please.
Yes, yeah. Thank you, Anna, for sharing that. I think one of the issues for Indigenous people and others, even in the state of Washington, is rurality, right? I mean, I have a dear friend who's vice president of the Oglala Sioux tribe on the Pine Ridge Reservation, which is huge, and there's not a lot of mobility. It's a very rural area. There's not public transportation. And, there's only one hospital on the entire reservation that actually could hold the Pfizer vaccine, because we know of it needs to be kept at minus 90 degrees. So I think that that's also an issue with some of the other rural locations. I'm assuming in Washington state, but I know for Indigenous people and other people of color who live in frontier rural communities, that's an issue as well, how to get people around to vaccination sites. So mobile sites, I think, are excellent. I think Dr. Robin Nurin, asked a question about mobile sites, and yeah, that would be a great idea. I don't know who we recommend those things to, but yeah.
I want to pick up on something Dr. McCormick said and direct it to Dr. Wallace, who hasn't had an opportunity to join the conversation just yet. Dr. McCormick mentioned in his anecdote that the role of fear, that people who might be afraid of vaccination or of getting sick. Dr. Wallace, could you share a little bit about some of the work you've been doing to address those kinds of fears and hesitancy, particularly among our BIPOC communities?
Sure. Hopefully you can hear me.
Yes.
I think that there's a couple of strategies to respond to the concerns and fears that people have. First is to acknowledge that people have a right to their feelings, and really meet people where they are in their process. I think it's important to affirm where people are in terms of their understanding of the process and not minimize or sort of diminish, their concern. I think that people are concerned, that people are communicating their concerns, to me is an indication that this is an important issue for people. And I think that should be honored. But beyond that, I think speaking to the issues directly, there are things that, and all the presenters here have talked eloquently about, there are things that we know at this moment based on the data and based on where we are in studying this virus, as well as the work of rolling out the vaccines. And then there are things that we aren't aware of yet that we need to continue to study and research and look further into, particularly some of the nuances around homebound persons and vaccinations and some of the other topics that have come up in this conversation. So again, I think speaking directly to the concerns, using plain language. You know, I think the other part of this, and I think Michelle alluded to this as well, is that part of this is not just about what you say as the message, it's also about who is saying it. And so if you have a trusted relationship with communities, then thinking about how you communicate this information is critically important, but also recognizing that you may not be the best person to communicate this information to someone. So, you know, identify who those appropriate people may be, empower them with the information so that they can share the information amongst their communities directly.
Absolutely, and that's certainly one of the goals of this webinar, is to help empower our audience today to be people who can go out and share this information. And Dr. Wallace, thank you. You gave me a perfect segue into a question for Sally. Sally, Arthur has asked about the choices that you made for the voices that are used in narrating the different video clips, and whether you include a variety of voices from various ethnic groups in that effort.
Yes, we do, is the short answer. And as you look at the different pieces, that you will see that we've been very conscious of that, and having a breadth of voices across both the animation pieces and who are the speakers answering some of the questions that Stefan just talked about, the importance of that.
Great, thank you. There was a really important question. Hang on, I have to scroll back to it so I ask it correctly. Lisa asked, with the new mutations that are occurring, what are the issues for the delays in vaccine rollout? Or do we need to encourage people to get vaccines quicker? Do we expect, you know, when we hear about the vaccines with these variant viruses, what is important to consider here? Allison or Anna, I don't know if maybe you're our best folks to address that.
I think we have a long history of working with respiratory viruses where our vaccines aren't perfect, but they do provide substantial protection. And that's sort of our situation every year with the influenza vaccine. Some years it's a better match than others, but it's been proven time and time again to reduce mortality and to reduce hospitalizations. So until we have better information, the vaccination is still a great plan for responding to and dealing with both the main virus and all the variants to it. But the world of scientists who study respiratory viruses are very experienced with the issue of variants and how to respond to them. So I personally trust that we're just going to keep gathering this data and we'll be able to respond to it appropriately, as we have in the past to influenza, where this is a big issue.
Yeah.
And maybe just to add that already vaccines that address the new variants are under development.
Yes, and we've just started to see some of the first data coming out about this, that we do see that the Moderna and Pfizer vaccines appear to be effective against the variants, although a bit less effective against the South African variant in particular. So we may continue to see that there's some variability in how well the vaccines address this. So important to keep an eye on the continuing data that will emerge about this over time.
Gail, can I say one more thing about voice that Sally addressed a minute ago? It was a good question. You know, we humans communicate in lots of ways besides with our voices. This has to do with masking, hand washing, and all the things we're going to continue to have to do for the next several months at least. There's probably a fourth good reason to keep wearing masks, in addition to the fact that we don't really know how transmissible it is even after vaccination. And that is the message we send by wearing a mask or not. If we get a little lax and say, well, I'm vaccinated, I feel terrific, I'm going to take this mask off for a while because it's bugging me. The more we do that, when others see us, the message we're sending is, guess you don't have to wear a mask anymore around here. So I think that's the other important reason to keep wearing one. We've gotten good at wearing them It's just no big deal to wear a mask. Let's keep doing it for probably at least another half a year or so.
Yeah, I think that's a great point. The positive peer pressure that that can be exuded if we continue to model best practice. That's helpful. Michelle, through your work with the mayor's task force, I wonder if you could talk about, Valerie had a question around whether organizations are working with the Seattle Housing Authority and King County Housing Authority for these mobile vaccine sites. Can you maybe say a little more about who's involved in that effort?
Yeah, so the people who are involved in the effort are the Seattle King County Department of Health, and I know that they have partnerships with multiple organizations around King County, but honestly, I don't know what those partnerships are, the extent of those partnerships. I know currently the focus has really been on, trying to make sure that we have coverage, particularly in areas of King County that are hardest hit and may not have, access there. I know that initially the county was thinking about utilizing these large vaccination sites, but what we've been seeing here and across the country is that even if you have a large vaccination site in a BIPOC community, people from outside of those communities often come in and take up those slots, and there have been a lot of challenges with that. So now the focus has been on really identifying specific sites in communities, working with community leaders and community-based organizations to fill the slots in those sites with people from those communities. And so those conversations have just started last week and are moving forward, and they are working, we're working to identify sites and community partners for that effort.
Excellent, thank you. I'm just scanning back through the questions to make sure if we've missed any. There was a question just in from Jan about, she's curious about anyone's thoughts around opening up K through 12 schools and allowing students and teachers back to class. Do we need to be paying attention to vaccinating teachers before returning to the classroom? What happens? There's so many facets to this question, so I'll open it up to any of you who might want to chime in on any part of it.
Well, I have kids who are currently home from school, so I think about this a lot. I think that the debate about K-12 is heartbreaking because it's talking about a heartbreak that we're all seeing for our children, for the children in our community, and also for our teachers who are treasured members of our community family as well. So the issue with COVID-19 is that interior spaces are risky under any circumstance. And there's a lot of debate over, children and their age and how risky and this and that. But no matter what, interior spaces are risky, and people who are going to be spending a lot of time in interior spaces in large groups of people need to take active steps to mitigate their risk of infection. So one of those tools is vaccination, and of course it should be rolled out as soon as possible. The other tools are ventilation and personal protective equipment. So I think getting hung up on the vaccination question, vaccination is very important for schools, but schools also need to be sure that they're addressing each of the prongs of the prevention table for COVID-19, and thinking that vaccination is going to get us out of having to address ventilation and personal protective equipment is wrong. Relying solely on personal protective equipment and ignoring ventilation is wrong. And just waiting for vaccination, we have to really weigh the risks and benefits of what could be a long wait. So those are the issues at stake. But vaccination is not going to solve the school question. It will just help with one of the aspects of making schools safe. That's my assessment, and I'd love to hear other people's opinions.
I mean, I agree. I think this is, again, a very difficult issue. I have a very close friend who is a teacher. She does not yet qualify for vaccines. She's very high risk. She works at a public school in South Seattle, King County, where there is a lots of infection. So, you know, even though I understand theoretically that we could go back to school without vaccinating teachers, I think clearly people who are essential workers like teachers have died during on-job exposure. And I'm very concerned about occupational risk of this virus. So, you know, I'm just hoping to get lots of vaccines soon and be able to immunize everybody. I don't see a different way out of it. I do think we need to keep all the other physical barriers, whether masks or distancing and ventilation, in place as well. But they all need to be together, integrated.
And Anna, you make a great point that, you know, part of the way forward is to have more than just these first 2 vaccines. We know that Janssen is now preparing their application to the FDA, and we hope that that one will be coming available, you know, maybe as early as later this month, maybe in March. You know, it's hard to predict the timelines exactly. We know Allison mentioned in her slides that AstraZeneca is accumulating their data, and they hope to be able to apply to the FDA as well in the coming short term. And then we have Novavax. The study is in progress. It's more than half enrolled at this point. So, you know, we look forward to having the data from the Novavax study in the coming months. And we know that there's yet another study from Sanofi that'll be coming in, I believe April is the projected timeline when that study will open. So, you know, each of these new companies entering the ring brings with it the promise of millions more doses, and that will increase the speed at which vaccines can be rolled out. So we keep our fingers crossed, and, you know, all the prayers to all the gods and goddesses and higher powers of all the different backgrounds are welcome, because it's going to take all of these different tactics to get us there. It looks like there was an interesting question, and I don't remember hearing it really elaborated much. Megan was asking about cancer patients in the clinical trials. And Allison, I wonder if you could circle back to this one. Are there any concerns about people who are receiving cancer treatment and what that might mean for vaccine efficacy or timing of vaccination?
Yeah, actually, Anna, it looks like you're answering this. Do you want to take this one about cancer?
Sure.
Please.
To my knowledge, the trial specifically looking at immunocompromised people, so whether people with cancer or transplants, are just starting to open up. And my recommendation would be that if your turn comes up for other reasons and you can be vaccinated, is to get vaccinated now. I think in the next 6 months, we'll have more sophisticated ways of being able to evaluate how well the vaccine worked. So people will be able to have a blood test, hopefully, and will understand what antibody level we're looking for after vaccination that would protect you. And then there can be decisions made about some people perhaps needing boosters if they were immunocompromised at the time of the vaccination.
Great answer. And Allison, I'm going to pass this one to you first. Olivier asked about the new hubbub that's making the media around the double masking and any guidance around double masking. Do you want to maybe talk about that a little bit?
Yeah, so this is why people have been talking about variants so much. So there are several variants circulating right now in Europe that are about twice as contagious as the coronavirus that we've known in our communities up to now. And what we saw in the United Kingdom and possibly in Los Angeles was a very, very high increase in cases in a very short period of time. That's because the virus is actually different and it's more contagious. So the recommendation about double masking is really part of this overall sense that these variants are coming They're in our communities. We've definitely detected some in Tacoma and Everett. And what happens is that these variants, because they're more contagious, they quickly become the main virus that's being transmitted in a community. So now is the time for people to evaluate what they've been doing to keep themselves safe and see if there's any way they can improve their prevention methods that they're taking to avoid, to understand that we're now working with a more contagious virus, and what can we do? So the idea of double masking is just the sense that if your mask is a little bit leaky, or maybe it doesn't fit as well, or like me, I've been using a cloth mask that somebody gave me about 9 months ago that's been through the wash 100 times, now is the time to look at the information we have and see what you can do to make sure your mask is as effective as it can be. So some of the techniques of doing that are just, number one, checking the fit of your mask. Number two, making sure that your mask has multiple layers and is not a single layer of fabric. Number three, if you're able to look for a hospital grade mask or a KN95 mask, that may be something to check on. But really, it's more an opportunity to think to yourself, okay, what do I usually do to protect myself against COVID-19? And what can I do to up my game? Because within a couple of weeks, these more contagious viruses will be circulating. And so maybe things that I've been getting away with up to now will not be protecting me with this more contagious virus.
That's a great way to think about it. How do I up my game? I love that. Love that frame. Thank you, Allison. I saw a question from Renee, and Michelle, you noted that you wanted to answer this out loud. If people are interested in having a presentation for their organization or their school, how can we help them?
Yeah, so we have a list of speakers, and maybe I said we could answer that live, but I really would like to punt it over to Stefan and Louis, because they're really handling the Speakers Bureau. So Stefan and Louis, I'll just pass that off to you.
Yeah, we have a Speakers Bureau of right now a little bit under 100 speakers, actually. And these persons represent different areas of science, bench science, lab science, social and behavioral science, clinical care. And they're across different race and ethnic groups as well. So if you have an event or an activity that you would like to have someone come and talk about COVID-19 specifically, the science, again, from a social and behavioral lens, from a health equity lens, from a research lens, from a clinical care lens, across different populations, please reach out to us. The link to request a speaker is on the COVID Prevention Network website on the About tab or About Us tab. And if you can, please request a speaker at minimum 2 weeks prior to your event, and we will try to link you to a speaker. We do not have capacity to organize events, unfortunately, for our community partners, but we will work to link you to a speaker from our Speakers Bureau.
Excellent. With our last few minutes remaining, I wanted to turn back to all of our panelists and see if you feel like there's any closing comments that you might like to make. Are there questions that maybe didn't come up organically that you want to make sure we touch on? Information that we haven't had an opportunity to share yet? Closing thoughts? Anyone?
Well, I would just like to add that we are in the process of building a website with vaccine education materials for Washington. And the URL will be preventcovidwa.org. So we are working hard on it. But a lot of these materials will live there in a dynamic way. It'll be mobile first, but also, obviously accessible on a browser. So look for that, and we're very excited to be launching it.
Excellent. Others?
Yeah, I just wanted to thank all of you for your work and just say that I've been so impressed with everything that's going on in the community around making sure that the most vulnerable members of our community have access to vaccines. And all of you are part of that. And it's incredibly important. It's wonderful work, and it's work that really has to come from the communities themselves. And I think it's a big myth right now in the world of vaccines that fancy people need to come from outside and do this for others. I think every community has the capacity to plan and manage their own vaccine rollout, and that they should be in charge and be running the table for their own vaccine rollout. So I hope that the information that you have today helps you in those efforts. And I'm just so impressed with everything we're seeing at the community level for COVID-19 vaccine rollout. So thank you for everything that you're doing.
I will second that.
I just want to second that too and say, you know, Fred Hutch, the UW, all of the people who are the scientists, I don't know what happened. They're speaking community language. They're doing so well. And I just think it's almost like a spiritual experience. It's an opportunity for us to be generous and kind and loving and caring. And we should all absolutely take advantage of this. And I'm seeing it in everyone. It's just really beautiful.
Thank you, Bonnie, and right back at you. Thank you for leading the way and giving us a great example to follow. I'm seeing, let's see, lots of thank yous coming through the chat now. There is a question that I don't know the answer to. Sally or Lewis, you might know. When we post the video on YouTube, do we also post the chat so that people have the record of the answers that were typed as well as those that were spoken aloud? And I don't know how that works.
I don't either.
No, we don't post the chat.
Okay. Sorry about that. I wish we could, but thank you, Stefan, for knowing the answer. All righty. Well, we are at the end of our time together. I want to encourage everyone that joined us today that there's lots of materials available for you, and we hope that you'll check us out online at preventcovid.org is our website. We've got our YouTube channel. If you're not following us on social media, we would love to have you as additional followers. We are on Facebook and Instagram and Twitter. And you're welcome to repost and share and retweet all of our content to help push out its increased visibility to the communities that you serve. There's a lot of work to do, but we're all in it together, and we hope that you'll partner with us in making it happen and really trying to spread good, solid information. So thank you for being with us today. Thank you to all of our panelists for sharing your expertise. And it's been a pleasure. Have a great rest of your day, everyone. Take good care.
Thank you for inviting me.